Jim, thank you very much for coming in and for your talk.
Thank you. Well, thank you all for coming at this extremely early hour. I'm going to divide the talk up into some history. And normally I would talk about procedures, but I'm absolutely not going to do that, because when I talk to an audience in which most of the people are not radiation oncologists, everybody just nods off almost immediately. The fact of the matter is that urologists do a lot of brachytherapy in North America, but only a radiation oncologist could actually love it, you know, especially when you start talking about isodose contours and TG43 and gray and Centigray and so on. So I'm going to leave that out and get straight on to an analysis of the 5-year outcomes. And I'm going to do that in a very straightforward way. I'm going to define the cohort of patients I'm talking about, define the outcomes that I'll present, and show you the results. And I'll make some closing remarks and try to make sure they last long enough so there aren't any difficult questions. So you know that quite a long time ago there was an open freehand retropubic technique for placing radioactive sources into the prostate. And I think it would be fair to say that it was pretty much an unmitigated failure in the long run. And a fellow named Chera Yulu at the Miami School of Medicine in 1980, he described a new technique with a percutaneous transperineal approach as opposed to retropubic, using real-time transrectal ultrasound guidance and an integrated needle template. Now, I'm not quite sure who deserves credit for this, but the first paper by H.H. Holm from Copenhagen is in 1983, and I think he is credited as being the first person who actually used this technique in patients. But unfortunately, he used doses of radiation that were simply too low to be effective. And in 1987, Blasko, Grimm, and Ragday adopted the technique, and they raised the dose to 160 gray, which was what they intended to give at Memorial Sloan Kettering. Of course, they very rarely actually achieved that at Memorial. By 1994, I attended the first course that I went to in this subject, and I thought the relapse-free survival figures were considerably superior to what we were seeing in the PSA era with external beam radiation therapy. The first program started in Canada under Dr. Jean Waugh, who subsequently, unfortunately, died at quite a young age in Quebec City. In January of 1998, the first program in English Canada began doing implants at the Toronto Sunnybrook Regional Cancer Centre. Our program was actually founded in November of 1997, and the reason that it was founded fairly early compared to some of the other Canadian centres is, of course, that patients by this time were leaving in droves to go to Seattle to have implants, and then they would come back and try to recover their costs from the provincial government, and that turned out to be a very expensive process, and it was giving a lot of very adverse publicity to the government. They are very adverse to that, as you know. And that combined with some internal lobbying, which would have been completely inadequate without the patient demand, frankly. But it caused the government to fund a program. So it was founded in November 97 amid some controversy. The first implants were actually done July 20th of 1998. All of the cases that we've done have used the standard Seattle pre-plan technique. We've always used I-125 sources of that sort of strength that's indicated there, and we use a planning manual algorithm. These are the people on the first day of doing implants, and these are really the founders of the program in the first year or two that really drove the process and made it successful. Today, it's the largest program in Canada. We've done nearly 1,600 implants. We typically do 6 cases a week. We now have 10 radiation oncologists that are qualified in the procedure, trained in-house. We have training guidelines for that. More importantly, all 4 of the BC cancer centers actually have trained staff and the necessary equipment to do this procedure. Now, the way it actually works is all of the patients come to Vancouver and have the procedure done at the BCC operating room. But the oncologist, Ross Halpern at the Cancer Center for the Southern Ontario, he will fly down and do 3 cases on a Thursday, and then patients from Kelowna, and then they'll go back there. So it's an academic program. We have 8 papers, more than 60 abstracts. Most of this stuff is about topics that you would guess: erectile dysfunction, acute urinary retention, other types of urinary and rectal toxicity, mainly seeking correlations with post-implant dosimetry. We've got 2 ongoing randomized controlled trials in brachytherapy, and a 3rd to open soon. I have a grant to develop a national brachytherapy database with other investigators across the country, and recently got a grant working on advanced imaging, robotics, and real-time dosimetry. But I said I'd get right on to describing outcomes, and what I want to do then is define the cohort, define the outcomes, and display the results. So the cohort that I'm going to talk about is all of the first 506 consecutive patients. So everyone from implant number 1 to implant 506. And the disease status for these patients is updated just to November 15th of last year. So the median follow-up is now 56 months. The eligibility criteria for patients were they either had low-risk prostate cancer, and I think most of us would agree with this definition: T1 and T2, Gleason less than or equal to 6, IPSA less than or equal to 10. These are the Canadian consensus guidelines. And then we took the bottom half of the Canadian consensus low intermediate risk group. So these are T1s and T2s with Gleason 7, but an IPSA less than or equal to 10. Or we could take them with a PSA up to 15, provided the Gleason score was less than or equal to 6. And of course, they had to be fit for general or spinal and have a prostate volume of nowadays around 50 cc's. If we look at the by clinical stage, you see that about 43% of them are T1C and T2A equal numbers. T2B is a smaller component. Gleason sum, the vast majority were Gleason 6 or less, but there were about 82 patients, or there were exactly 82 patients with Gleason 7 disease. The median IPSA was 6.5, mean 5.9. You can see that, again, most of the patients fell in the 4 to 10 range, about 65%, but a significant number of patients were over 10. If we use the Canadian consensus risk group stratification, we would find that 60% are low risk and 40% are intermediate risk. But they're not unselected intermediate risk, and I acknowledge that point. The treatment protocol was if you had low-risk disease, you went straight on to have a brachytherapy implant. If you had low-tier intermediate risk, you had 3 months of hormone therapy before the implant and 3 months after. And hormone therapy was also used to achieve volume reduction, and frankly, quite a lot of low-risk patients in those era came in on hormone therapy by the urologist. If they were, we kept them on for the standard 6 months. So overall, in this particular cohort of patients, 70% of them actually received hormone therapy and brachytherapy, and 30% brachy alone. Just over 95% of all the implants in this cohort were done by 5 radiation oncologists. There were 3 other that had at least 1 case. And we now use exclusively stranded seeds. They're in a sort of a train. But these cases were almost all done with loose sources, which does not give as favorable a dosimetry in our opinion. No patient received supplemental external beam radiation therapy. No patient received a supplemental or revision implant. and no patient was continued on androgen suppression beyond the 6 months. This is the age distribution of these patients. Median was 66 years. You can see that the vast majority of patients fell in the 60 to 75 range. There are quite a number of younger patients. So defining the outcomes. Well, I think there's one thing that radiation oncologists and urologists could agree about is that we can agree when a patient's actually dead. So survival is not going to be difficult for us to define. So I'm going to start with that. These ones that are grayed out, I'll come back to in a minute, and we'll talk about those in greater detail. So overall survival, 506, median follow-up 56 months. There have been 27 deaths. One of those was from metastatic prostate cancer. Of the remaining 26, none of those patients had clinical, radiological, or biochemical evidence of persistent or recurrent disease at the time of death. There were no treatment-related deaths. This is a Kaplan-Meier plot showing the 5-year overall survival at 95% with a confidence interval from about 93 to 97%. You can see that these data are reliable out to 60 months. We've got 206 patients beyond 60-month follow-up, which gives us a fairly small confidence interval around the 60-month point. I'm not going to be making claims beyond 60 months, but I will discuss that issue in some detail in a minute. In a Cox regression, multivariate regression for overall survival, none of these covariates, as you can see, seem to predict for overall survival. I guess I'm a little disappointed that age didn't, but the rest of them I suspected would not. We wanted to look at overall survival by use of hormone therapy because there's been quite a lot of recent publicity suggesting that the use of hormone therapy, even short-term hormone therapy, in patients with low or intermediate risk disease actually causes a decrease in their overall survival. We were unable to see that. The blue curve is patients without hormone therapy, and the black is with. And if we look at the 95%, sorry, this seems a little slow, the 95% confidence intervals here, you can see they widely overlap, and the log rank p-value is non-significant. So now, we're out of the uncontroversial part, I guess. We can all agree about survival. What about relapse-free survival? Clearly, that's going to depend a bit on how you define it. And that's always been a point of contention between radiation oncologists and urologists. So I want to spend a little bit of time about this. First of all, what we mean by relapse-free survival, what I'm going to use for that measure, is if a patient has clinical local tumor progression, if they have X-rays, CT, or bone scan evidence of lymphatic or hematologous metastasis, they've obviously failed. But they also fail if they have a PSA failure by the Houston definition. So what is the Houston definition? Well, it's defined as the date when a follow-up PSA value is greater than 2 nanograms per ml above the nadir level. So whatever the lowest level is. So most often in our patients, the lowest level is about 0.1, so or below. So these patients typically, when the PSA reaches just over 2 nanograms, they would be scored as a relapse. Now, why do we use this instead of the ASTRO definition or some other definition? Well, I guess I'd have to say that there's been a huge amount of work on this in the last 4 or 5 years. And in fact, British Columbia Cancer Agency, led by Tom Pickles, has actually done some of the best work in the area of the definition of PSA failure. And there have been consensus meetings and there have been many presentations. The bottom line here is that there's several large long-term databases, and this simply has the best negative and positive predictive value for actual outcomes for the patients. More importantly here is that it's also valid for patients who receive neoadjuvant hormone therapy. It does not produce false plateaus, as opposed to the ASTRO definition, and it's equally valid in patients receiving brachytherapy or external beam radiation therapy. However, this is the problem, I guess, is that most people would say, that patients treated surgically, usually they're taken to have biochemical recurrence when the PSA is greater than 0.2 nanograms per ml. That's 10 times lower. So I guess the question that a surgeon would naturally ask is, well, how can you compare that? I mean, is that fair? Is that reasonable? Well, first of all, I'm not going to make any comparisons. So I welcome you to make the comparisons, if you will. It seems to me that we've chosen a definition that fits well with the actual outcomes for patients, and I guess the 0.2 for the case of surgical patients also fits with their outcomes. But anyway, I'm not going to make any direct comparisons. Secondly, I'd say that mature data sets seem to yield the same results, independent of the definition used. So eventually, long enough follow-up, ASTRO and the ASTRO consensus definition and the Houston definition produce exactly the same result. But lastly, I hope to convince you that the data and conclusions that I present here are simply not sensitive in any way to the definition of PSA failure. Well, relapse-free survival, then, there have been 20 recurrences, including 1 death from prostate cancer, which I already mentioned. 4 have been local, 3 distant, 2 nodal, and 11 are PSA only. I think very important point is that none of the patients that have failed in any way at all did not, I guess I should put it the other way around, all of the patients who did fail in any way had a preceding or simultaneous biochemical recurrence. So the relapse-free survival, again at 5 years on Kaplan-Meier plots, is just about identical to the overall survival at 95, with a confidence interval again at 5 years between 93 and just about 97%. Again, I would stress that these data are mature to 5 years. I'm not making claims beyond 5 years. I've done a huge number of pairwise comparisons. This is Gleason 7 versus the patients who had Gleason less than or equal to 6. And as you can see here, the 95%, where am I? There it is. The 95% confidence intervals overlap, and again, a non-significant p-value. We looked at intermediate risk versus low. I mean, both this and the Gleason 7 things actually come out backwards of the way you might have expected them to. And the lines cross, which is, indicates that they're not likely to be different. Again, the log rank p-value, this mouse takes forever to warm up every time I stop. There it is obviously non-significant. If we do a Cox regression for relapse-free survival with the same list of covariates that I used initially, you can see that the log IPSA comes out as a significant predictor. And if we look at that, if we look at patients that had PSAs above and below the mean value of 5.9, they do seem to separate quite nicely. And this is confirmed again on log rank comparison. But I don't know that we can make all that much of it. But first, just before I do that, let me just point out that this applies for patients that had hormone therapy on the left here, on your left, and those that did not have hormone therapy as well. But if we divide it for patients that had less than 10 versus greater than 10, we no longer see any separation of the lines at all. And in fact, again, they're kind of reversed, where the patients you would expect to be doing worse are doing at least as well, perhaps slightly better. And again, it's not a significant difference. So I'm not even sure that IPSA is going to be a good predictor, at least within the range that we have here. We looked at dosimetry parameters. I'll be very brief with this, but we look at things like a median V100. Now, the V100 is the volume, the proportion of the prostate volume that receives at least 100% of the prescription dose. Now, much of it will receive more than that, but at least that much. So our median V100 in this series of patients is 92%. These are good figures by international standards. Median V100 or V150, which is the amount getting at least 150%, is also pretty high. The other one I would point out to you that's important, I guess, is the D90. And the D90 is about 104% of the prescription dose. Again, what that means is that that's the dose received, or minimum dose received by the 90% of the prostate, basically. So post-implant dosimetric data are available on about 91% or 90.5% of these patients. And of course, as luck would have it, 3 of the patients that had recurrence don't have dosimetric information. So if we add those to the Cox regression for relapse-free survival, what we see is that they do not contribute in any way to the relapse-free survival statistics. The log IPSA, again, appears to be highly significant, and so is age in this particular thing, with a trend favoring younger patients doing better than older patients. So if we look at V100 as a function of D90, so the V100, remember, is the proportion of the prostate that receives at least 100%, and it obviously cannot go above 100%. Once you get 100% of the volume there, that's the max. So it's an asymptote. And at the bottom, we have the D90, which is the percent of the prescription dose. And that can be anything from 30% to 250%. Now, what you see if you look here is that the arrows represent the median values. And what you see is that most of the points fall on a curve that we'd expect. The small circular points are for patients that have not relapsed. The red triangles are for patients that have died of any cause, and that doesn't seem to be any relationship. And the smaller black rectangles represent patients that have relapsed but have not died. And there doesn't seem to be any strong correlation between the dose and whether or not a patient relapses or dies. That's all I'm really showing there. Complications in this group of patients, there were no treatment-related deaths. 3% of the patients had prolonged urinary obstruction. That means, by our definition, is requiring catheter diversion for greater than 21 days. 8 men have required a transurethral prostatic resection for benign stricture. There's a patient that Larry's seeing shortly who has quite a bad local recurrence causing outlet obstruction, and he is certainly going to require a palliative TUPR. No implants needed to be abandoned because of pubic arch interference, and no patient has required permanent urinary or fecal diversion as a result of radiation injury. Now, that's in a different color because, as most of you will know by now, there are 2 patients who have had serious rectal injuries from our brachytherapy program and have had permanent fecal diversion. They are not patients in this cohort, but they do exist, and it's clear that the risk of this must be at around 1 in 500 or thereabouts. So summarize the results then. 506 patients. If we look as of November 15th at their status, we see that 460 of them are alive without evidence of disease, 26 are dead without evidence of disease, 19 alive with disease, and 1 dead of disease, giving a crude relapse-free survival of 96%. The 5-year actuarial is 95.2%. And I guess the point I'd make here is that I've tried to demonstrate there are no clear correlations that tie the 5-year outcomes to any prognostic factors, and I think there's 3 reasons for that. First of all, there's a real paucity of recurrence events. We only have 20 events, and so doing any kind of statistical analysis with that small number is always going to be very difficult. We also used very narrowly defined eligibility criteria, so we didn't have patients in wide range of risk categories with a wide range of differing risks of relapse. And again, that makes it more difficult to find prognostic factors. And apparently our dosimetry, if not perfect, was adequate virtually from the start of the program in the vast majority of patients. So the closing remarks, Are the remissions durable? I think that's the question that everybody really wants answered. And I'm going to tell you about some trials in brachytherapy and some perspectives on this ageless question now, I guess, of surgery versus brachytherapy. Well, what I've done here is I've compressed one of these Kaplan-Meier plots for relapse-free survival to the point where now the 60-month is here at 5 years. And you can see the relapse-free survival curve. And this black line simply represents a 1% recurrence risk per year carried on indefinitely, which is so far what we've seen. At 5 years, 5% have recurred. So a 1% risk of recurrence per year. Now, if you did that at 15 years, you'd have obviously 85% of patients being free of recurrence. The question is, does this curve plateau a bit? We don't often see much evidence of plateauing in radiation therapy treated patients, and frankly, I haven't seen much evidence of plateaus in patients treated surgically either, but perhaps you could correct me on that. I don't think that's likely to occur, actually, but it may. The question really is, are we going to get these pink or red kind of curves where we get an accelerated rate of recurrence so that although the patients did well out to 5 years, they begin to have a rapid rate of failure thereafter? Is that likely to happen? Well, in the literature, that has not happened in centers that have long follow-up. But I'm not going to make any definite claims here. But I'll try to convince you that I think those kind of steeply accelerating curves, at least, like this one, is exceedingly unlikely, actually. So the median follow-up in our patients at latest follow-up is 0.04 nanograms per ml. Now, to surgeons, that's nothing because they're usually 0.02 or less when you see them and they're successful. But to a radiation oncologist, that's an astonishing accomplishment because that's about, it's many times lower than the PSAs at 4 years following external beam radiation therapy in non-failing patients, where it's typically 0.5, 0.6, those kind of numbers. So in a subgroup of these 348 men then that had greater than 48-month follow-up, only 8 of them have a PSA greater than 0.5, just 2.3%. In fact, only less than 10% of them have a PSA greater than 0.2. So we could use a surgical definition and actually have results that are not all that much different than what I've shown you. 143 or 40% of these patients actually have an undetectable PSA. Now, there have been a number of important studies that have shown that men that have a PSA value of less than 0.5 at 5 years after external beam radiation therapy have a really quite low risk of recurrence in the subsequent 5 years. So it working out to about 2% per year. So I think there may be some acceleration in that curve, but I would bet on a fairly flat line straight out to 15 years. Well, I'd like to just spend a minute talking about trials that are ongoing at the BC Cancer Agency. My favorite, of course, because I've been working on this for years, is the ASCENDE-RT trial. Stands for androgen suppression combined with elective nodal and dose-escalated radiation therapy. It's an investigator-driven, industry-sponsored sequential trial. And as you can see, it's supported by Sanofi, Aventis, and Oncura. It's for intermediate, that is the high-tier intermediate, not the low-tier intermediate that we're treating with Brac here, and high-risk localized prostate cancer, provided the IPSA is less than or equal to 40 and clinical stage is less than or equal to T3A. We don't feel that we can implant seminal vesicles, and we don't think patients that have T4 disease should be included. And the arms for this randomized trial are androgen suppression for 8 months neoadjuvantly plus 4 months concomitant and adjuvant, elective nodal irradiation to 46 gray, and then a 2-phase high-dose 3D conformal external beam radiation boost another 32 gray, bringing the dose to 78 gray, which is about as high as you can go with conventional technology in external radiation. In arm 2, everything's the same except they get a brachytherapy boost instead of the external beam boost. The primary endpoint is 5-year relapse-free survival by the Houston definition and the secondary endpoints that you see. So far, we did this as a sequential trial. The phase 2 opened in November of 2002 and closed in July of 2003, accrued 41 patients. And then we reopened the trial when more funds were available last year in August. And so far, altogether, 157 patients have been randomized in this study. The aim is eventually to get 400 patients. There's another trial called 6x1 versus 2x3. Dr. Eric Berthollet is the principal investigator and sponsored by Abbott. And this is for patients that need to have hormone therapy by protocol or for cytoreduction. They're randomly assigned to receive 1 month depot Lupron times 6 or 3 months depot Lupron times 2. Endpoints being time to testosterone recovery, quality of life, and sexual function. Another trial that I'm hoping that we will start within 6 months is called MVRT, intensity modulated versus interstitial radiation therapy. This is the latest thing is intensity modulated radiation therapy. It's a form of external beam treatment that can deliver extremely high doses and has some of the advantages of brachytherapy. It purports to produce a similar low recurrence risk with much fewer adverse urinary side effects. So we're hoping to do a trial comparing them head to head. And lastly, I said I'd talk about surgery versus brachytherapy. Do you go under the knife or do you get turned into a living radiation source? Because these guys do have quite a lot of radiation, actually. Well, let's look at it from my perspective, and yours will be very different. But radical prostatectomy, these are the advantages that I think of when I think of radical prostatectomy. The definitive appeal of the knife. It really is awfully nice, you know, and patients know that. I mean, the idea of having this thing in a pathologist's jar is very, very appealing. Okay? There's no question about it. And the other advantage, and I think it maybe is the most important advantage, is that when you're over the worst of it, and there is some bad parts, let's be realistic here, you're probably over the worst of it, for real. We don't quite have the same advantage. The disadvantage of surgery is that something like 20 or 30% of patients will end up needing to have adjuvant or salvage radiation therapy, so that some of the advantages of surgery are erased for a significant proportion of patients. And I think there's a much greater incidence of erectile dysfunction, certainly in the first few years. Now, whether they're different in the long run, I think, is another question. So I put it this way. I think it's great when it works, and the new technology with your Da Vinci robots and all that stuff is keeping surgery competitive. I don't think you have to worry about it. It's going to carry on being competitive. Iodine brachytherapy. Well, it's a daycare procedure with a very low risk of grade 3 or greater complications. There's, as I've shown you, a very low recurrence risk in the first 5 years. The disadvantages are really also there. You can never be certain that the worst is over. Radiation can come back to bite you 10 years, 15 years, 20 years later. There's no question that it can. The only real question is, what's the probability of that occurring? And we actually don't have enough data to really give you definitive answers on that. There's also concern that the long-term results will show accelerated rates of recurrence. I think it's a legitimate concern. I don't think it'll happen, but I'll be back here in 3 or 4 years and let you know. I think there's no question that it's the radiotherapy technique of choice. If we compare head-to-head what we can achieve with conventional radiation in terms of relapse-free survival with brachytherapy, it's 4 to 6 times better for a given risk group of patients. It's competitive, in my opinion, with any other treatment, and I guess the real concern is second cancers may reduce the long-term benefits. So the question of surgery versus brachytherapy. Well, just one other point needs to be brought up. How many men last year had brachytherapy without a surgeon's opinion? Well, the answer is 0. Nobody. Not a 1. The symmetrical question of how many patients had a radical surgery without a second opinion from a radiation oncologist, we're not quite sure, but it's more than 400. So there's a lot of asymmetry there. Should we worry about cost? Well, frankly, I don't know. And in fact, I don't know which costs more. And I guess it depends on the technology. I think if you go to the Henry Ford Center and you have the Da Vinci robot and all that stuff, it's $80,000 to have a radical. But across the street at VGH, I think you guys are barely getting any money at all for it. And that's what I hear anyway. It's practically, it's a gratis thing, isn't it? So in any case, it doesn't really matter because health insurance here covers both of them equally well. Nobody's arguing about that issue. So surgery or brachytherapy, I think the question is, or the one I think, is that cost is no issue, but getting to choose is priceless. Thank you.
Thanks, Jim. Once again, as always, a very honest presentation. Before you leave the call, thanks for watching.
We have lots of time for questions.
We have time for questions. I'll just start off on the last slide there with the number of patients who have had radical prostatectomies without seeing a radiation oncologist. I can only speak from my own practice, but patients who are candidates for brachytherapy, the low risk or low intermediate risk, are all offered a radiation oncology referral. Many of them decline because they come in having pre-read and having made a decision. So a good number of those 400 probably have declined the opportunity. Also, we are now tending to do higher risk patients in surgery who perhaps feel they don't want to have a radiation oncology consultation. So,
well, I would
put it in perspective. I mean, there certainly are, and I'm sure there are a lot of practices where surgeons are telling patients that brachytherapy is a good second choice, and for one of the reasons you showed.
Yeah.
But this is the real world. Until we have a head-to-head study, which we tried to do and was unsuccessful, I don't think we'll ever be able to answer it. I think most surgeons would agree that for the low-risk patients and low intermediate risk patients, the results are great. The other thing is to complement our BCCA program, and many of them are here, the quality is important. Just like in surgery, we're finding that more and more papers are suggesting that the surgeon and the hospital are an independent predictor of outcome. I believe if you were to compare techniques of brachytherapy and the technicians, you would find that may very well be a variable as well.
Yeah.
So the quality of the procedure. I witnessed a brachytherapy procedure once where the seed didn't quite go where it was supposed to go on the plan, and the comment of the doctor putting in the seed was, well, it's close enough. If I said close enough when I was doing surgery, that wouldn't be good enough. So I think quality is very important too, and it probably reflects is a parameter that you don't comment on, but I will comment on.
Yeah.
Any other questions? Joel?
You commented on secondary cancer. Is this a theoretical concern, or is there any actual data that's like similar to previous experience with say, cervical cancer, where there's an increase of bladder cancer?
Yeah.
That you radiate the cervix, you're going to get more bladder cancer. Is there any actual data showing any trend or actual statistically significant increase of secondary cancer?
Well, that's, if you're speaking specifically about brachytherapy, it's been very poorly studied. I think that I would say that more broadly, radiation therapy, when it's used in curative setting and patients become long-term survivors, so whether it's seminoma or cervical cancer or uterine cancer or adjuvant rectal cancer or breast cancer or anything else, there is an increased risk of second malignancies in field. I have no reason to think that this is going to be different than that, and we certainly are going to study it very carefully. We don't expect, however, to see that evidence of that increased risk until we get out at least 10 years, and 15 to 20 is when it shows up more often in other studies. I think it is a real concern, and it's something that I discuss with young patients quite extensively at the time of consultation.
That's a big factor with patients. They often come in and they make their decision based on the fact that you can have surgery after radiation, they say.
Yeah.
Now, they have radiation after surgery,
Yeah.
but that surgery after radiation is impossible.
Yeah.
Someone tells them that. It's not impossible, it's just more difficult, more complicated.
Yeah.
That is part of their decision process.
Can I?
About whether they get another cancer later on,
Yeah.
operate later on.
I should repeat that for our listener in Prince George, or listeners I can't see very well, and also in another center. But the question or the comment that Larry made, I forgot to repeat the last question. I apologize for that. Was that patients come in with the notion that they can have radiation after surgery, but having the converse isn't true. And I agree with Larry. I think that if you deconstruct that phrase or that cliche, which I hear repeated every week. The surgeon told me that one of the advantages of having surgery is if it doesn't work out, I can always have radiation later. But if I have radiation, I'm cooked. That's it. Nothing else can be done. Now, what do you think of that? And that's how they present it to me. And I very carefully deconstruct that, and I say, well, why would you want to have radiation after surgery? Well, there's two reasons. One is the surgeon didn't get all the tumor, or it has bad adverse characteristics, which doesn't sound like a really good advertisement for surgery. Or the disease has recurred apparently locally, which likewise doesn't sound like a very good advertisement for surgery. But the fact is that salvage surgery can be done after brachytherapy, and surgeons that have done it that I've spoken to say that it's easier than doing it after external beam radiation. Now, we haven't sent anybody for salvage surgery yet. We haven't had a suitable candidate because local recurrence risk is so extremely low. We will eventually, and we'll send him to Larry or somebody, and you'll have lots of fun doing that. But I don't think that's a fair statement. I think you should not use that cliche when you're counseling patients. I also would take slight disagreement with Larry's comment that patients come in informed already about brachytherapy and have decided they don't want an opinion from a radiation oncologist. That's a slippery slope. I don't think you would like me to say that the patient has already read about surgery and has decided they don't want it. They don't need to see a surgeon. I don't think it's quite that simple. In the States, where perhaps there's more incentive because many urologists do brachytherapy, so they have a financial incentive as well to get involved. A much larger proportion of patients have brachytherapy than in Canada, where it's whether you swim upstream to get a referral or not. So I think it's a little bit more difficult, or it's not quite as simple as they didn't want an opinion. Anyway, just my view. Yeah. Question? Sorry.
I just wanted to make one quick comment about surgery after brachytherapy.
Yeah.
It's not quite long term, but I have been involved in one case about 1 week later after a failed brachy attempt. And it was, other than wearing the big gloves, blood gloves, it was just as easy as normal radical prostatectomy.
Yeah. Well, I mean, the comment that the questioner brought up was that he had done or been in a radical prostatectomy in a patient who had a failed brachytherapy procedure. I think there have been 5 procedures so far in which we simply could not do the implant properly because of bone interference from the pubic arch. And those patients have been sent for surgery in some cases. I don't think that's the same thing, though. I mean, we're talking about somebody who's, say, maybe 5 years out and is fibrosed down and now has recurrent tumor. I don't think you could compare that to the situation that you faced, which was a fresh patient with a few sources in it and it was no big deal, right? So they're different, I think, but I do think it'll work. Yeah. As you saw, I used order of implant in the multivariate analysis, and there's just no relationship. And although we did have a learning curve, I didn't bring the slide to show it in terms of dosimetry, we're better now than we were. We have a much lower acute urinary retention rate than we used to have, and so on. But apparently we got it more or less right from day one. Yeah. But it's a point, and Larry brought up the quality of it. Yeah, it is true, but there are several centers now that are producing results just like these. The question is whether all centers can do it, and clearly that's not going to happen. Yeah.
Any questions from Kelowna or Island or Prince George?
I see Dr. Kinahan. No questions?
No, good neighbor.
Thank you.
Okay, I'll approach first and then wait.
As somebody who is not involved with their prostate cancer anymore, how do you, and that's a question for you, Dr. Morris or Larry, how do you counsel your patients about watchful waiting, the low or intermediate, and what proportion of them would actually go that way nowadays?
Well, I'll let Larry comment as well. There's a big effort underway, I think, to make active surveillance a much larger proportion of our management of early-stage prostate cancer. That's what I would say. And we have been not at all successful, by and large, in getting patients in. A few hundred patients over the years have gone into a watchful waiting database. But I think there's going to be a renewed effort. I know there is locally. And many of these patients probably would have been just as well off having had no treatment.
I agree. All of my patients who are low risk are counseled to consider active surveillance as one of the three options. So I'll talk all three, I think, at this point in time. And, it is a bit of an apple and oranges story. But if they're monitored properly in active surveillance, we haven't lost anybody yet. I have over 100 patients in my practice on active surveillance. We're trying to develop a much larger initiative in British Columbia. And you'll be hearing more about that, not at Children's Hospital, but you'll be hearing more about it elsewhere. I think it's a good point. And what is the gold standard? We're not quite sure. William?
Thanks, Jim, in a very nice, careful paper. Just with regards to the pathology, this was a low-volume pathology, wasn't it?
The question was this all low-volume pathology? And the answer is no. We did not stratify patients according to the percent positive cores, and we took them whether they had bilateral or unilateral organ-confined disease. Now, I have not yet finished the analysis on percent positive cores and how that might correlate to outcomes, but I'm busy working on